Hello, my name is Todd Yates, and this is my final project presentation for our HI 7071 Advanced Database Design class. So an outline of what I'm going to go through during the presentation, go through the project setting or the project as it was presented to us as an assignment, what the options were and what I chose to do. And then we'll look at it being a data warehouse project. We'll look at the data sources that we created and what we needed from those data sources to populate the data warehouse. Then the data export and import process, export out of the data sources, the disparate data sources, and then import into the data warehouse. And we'll visit the schemas, starting first with the conceptual model. Next, we'll look at the logical model, which is the model for the physical database. And then a quick glance at the data dictionary, which will give you some insight into the logic behind how the data was stored. Next, we'll look at the reporting process, the query that executes, that produces the results, and how those results are presented. And then a little retrospective about what it was that I went through and learned in this project myself. So the project setting was for an imaginary company called Good Health Healthcare, GH, and they supposedly have 25 hospitals and 180 clinics, which would be widely dispersed, and because of that dispersion, there would be disparate data sources. So they're looking to look at or to mine data from those those disparate data sources for insights to help improve GH patient care. We were given a choice of two options. One was multi-drug resistant pathogens option, and the objective behind that was to identify admissions of new patients with previous MRSA or VRE positive cultures. It didn't interest me, so I chose the second, which was a high risk of venous thromboembolism or VTE. And the objective here was to identify patients with increased risk of VTE at admission or later, as they would accumulate more risk factors such as surgery duration or bed rest, and a couple others that we'll look at here in a few minutes. Pardon. The objective of the use of the data warehouse is to alert pharmacists to a heightened risk of VTE. And different risks can carry different point values. So what we do is we look at a variety of risks, add up point values for those, and any that total 4 or more, that flags a patient's chart for VTE prophylaxis if the physician chooses to prescribe that. So the data sources that we needed for the data warehouse, we chose two for the project. One was the EMR for quite a few factors there, and you can see lab was also a good source down at the bottom. So for the EMR, you'll notice there's a name on the left and a number on the right. Prior VTE, somebody's had a thromboembolism before, that's a big red flag, so it carries quite an impact at 3. Prior surgery carries not as big an impact, but it's still a fairly significant one at 2. And then a couple that are less impactful, but still worth noting. Excessive bed rest hours per week would be a flag. Hormone replacement therapy raises a flag. Oral contraceptive use raises a flag. And you can see the cancer risk has a very large impact on a score. Advanced age has an impact, as does body mass index or obesity. Looking at our lab data source, there's one piece of data in particular that has a very good impact, a very big impact, and that's hypercoagulability. So the data export-import process consists of this. First, we have to export it out of the EMR data source and the lab data source. And we put those into a file that's going to be a temp file. And you can see the SQL statement select star into out file, and the path for that's the EMR export, the admission underscore diagnosis CSV. and creates a CSV file from that table. The next step is to import those files into the data warehouse itself. So we do that using the SQL statement load data local in file and provide the path to the file we want to import. And that goes out, parses through that file, and imports it into the existing table. So the conceptual model is an ER diagram that kind of shows you the workflow. How a nurse typically admits a patient, patient's assigned a chart, they go through an evaluation conducted by a doctor who may or may not order a treatment or lab test, and a lab tech would perform that lab test and you'd get lab results who would be seen by a pharmacist who would establish a risk factor and a risk score. So the logical model is a little different, you'll see. The relationship between the staff and the patient is carried by the admission table in the upper left there. The evaluation table looks a little bit different than the conceptual model, but contains all the valid information that we need. And again, the physician may or may not order a prescription or a lab test. Lab tests come out. A risk score is evaluated from risk factors, and that would then populate the risk factor evaluation would populate the risk score table, which would then populate the chart flag table. And that's the act of flagging the patient's chart for the physician in charge, the physician in the patient's care, to evaluate whether or not prophylaxis was in order. One other piece that I added that wasn't a requirement was a data dictionary, just because it helped me keep track of so much information. You'll see we've got the columns across the top, data source table column, what the data type was, a description of the data, and then whether or not that data is required, whether or not nulls are allowed. So if you look at the second row, our data source was the EMR. If we were to scroll down, this is obviously a picture, a screen print, but if we were to scroll down, you would see the lab data source down below. The table in this case is the patient underscore CR, cancer risk, and the cancer risk score in the third column there, it's an integer. And if you look at the description, the binary 3/0 on whether the patient has risk factors for many types of cancer, with 3 being yes, 0 being no. Now, usually a binary choice is 1 or 0, but this one 3 or 0 because of the fact that if you remember back earlier, that patient having a cancer risk was very impactful on their score. It had a score of 3, and that's why the binary choice here is 3 or 0. So once we have data coming out of the EMR and going into the data warehouse, it's already prepped for manipulation in the data warehouse by way of being a score of 3. And if you look down a little more toward the center of the slide, you'll see that there's a binary 2/0 and a binary 1/0. And those were factors that were also noted in our list of factors, but having lesser impact than a couple of the others that would be 3 and 0. So the domain tells us, actually helps us calculate the risk score later on. So here's the query that actually executes in the data warehouse that selects the risk score. We select the different factors, risk factor, patient ID, so we know who we're identifying, and then we take the sum of the prior VTE, prior surgery, bed rest hours per week, hormone replacement therapy, oral contraceptive use, their cancer risk, their age, and BMI, and hypercoagulability, and we call that total risk score. And you can see I've given red underlines to 5 of the patients there in that output. The pharmacist would see that and say, we have a risk score of 4 or greater, and these 5 patients need to be flagged, their charts need to be flagged for a VTE prophylaxis if their doctor so chooses. So that's the impact of looking at the data in a different way and seeing what sort of a result we can get out that helps us with the decision. So what did I learn from this? This project was difficult. It was long and complex, and there were a lot of changes that had to happen midstream along the way, and that was all because of the complexity. And I certainly have a newfound respect. I work in IT, but I have a newfound respect for the complexity that DBAs and those that manage databases and design databases and maintain them, that they have to go through, just how incredibly complex this can get. Another thing that struck me about working with data was the urgent need for ongoing maintenance, that data is never done. There's constant reviews for security and data accuracy purposes, and there's just it's not a freebie. You know, if you want good information, it takes hard work and a lot of intelligent thought, and so that need for ongoing maintenance has really made an imprint on me. Probably the final thing that I would note is the need for adherence to standards and for naming conventions. This did come up to bite me a couple of times where I thought, I wish I hadn't named that. And so learning and adhering to the standards and naming conventions of the organization, really, really important, really critical. And because nobody's ever going to be in a position, you know, forever themselves, they're going to have to pass it along eventually. And for somebody to come in behind them and pick up that ongoing maintenance, they're going to need to be able to look to those standards and naming conventions and understand what it is that's out there. And when you get into a big organization, my goodness, I can only imagine the incredible risk for mistakes because of lack of adherence to standards and naming conventions. So anyway, this was a tough course, very challenging. I hope you were successful in your own efforts, and I'm glad this one's done. Anyway, thank you all for your time. I appreciate it. And on to the next course. We'll see you there.